Yes, very fantastic evening, doctors. Welcome to DAMS YouTube channel for NEET PG Predictor Pharmacology. So, my portion is to discuss the most important question predicted for near coming NEET PG examination from ANS, CVS, CNS, endocrine, and from GIT. Shall I start? Yes, good. All my dear students, fantastic. Good afternoon, good evening. Adi Ravi, Arjun Reddy, SK. Good. We start. Without wasting time, we start our discussion to start. The first question I'm going to discuss is okay, a 7-year-old child brought to the clinic by her parents for evaluation of frequent episodes of sudden blank stare lasting for 10 seconds. These episodes often accompanied by eyelid fluttering and occur multiple times a day. And each shows generalized 3 to 3 head spike and wave discharge, which are following anti-epileptic contraindicated in this patient. Answer? Yes. Somebody putting answer B, somebody D. The exact answer is, first of all, you should know it's a clear-cut case of absent seizure. 3 head spike and dome shaped discharge with the star looking clear cut case of absent seizure. In absent seizure, you should know the problem is in the thalamocortical circuit, and the problem is T type of calcium channel abnormality. So, for treating the absent seizure, you need some T type of calcium channel blocker. Among the given option, the best drug useful for this case, we can go for ethosuximide, a T-type CCV, valproate having multiple mechanisms, including T-type of calcium blocking, acetazolamide, a carbonic anhydrase enzyme inhibitor, but that has anti-epileptic property. As an anti-epileptic, it can be useful for absence also. So the answer for the question option is carbamazepine. Carbamazepine actually a sodium channel blocking group of anti-epileptic. Here the problem is due to T type of calcium channel. So for this case, we need some T type of CCB. In fact, carbamazepine and other sodium channel blocking drug like phenytoin going to worsen absence seizure. So the answer for the question option number D. If you want to have still more explanation for this question, remember I just explained this. Acetazolamide, a carbonic anhydrase enzyme inhibitor, useful for so many things. One among the CNS use anti-epileptic, useful for catamenial seizure as well as for absent seizure. That's it. Fine. But when you talk about absent seizure, for absent seizure, the drug of choice go for ethosuximide. It's a clear-cut drug of choice for absence seizure because it's a T type of calcium blocker. But the point is, absence seizure sometimes present with some other problem like myoclonic jerk or tonic-clonic seizure. So, absence seizure with the extra problem in, then we can go for sodium valproate. So, the only absence seizure mean go for ethosuximide. Absence seizure with the associated problem mean go for valproate. What are the other drugs that can be useful for absence seizure? It can be lamotrigine. It's also one of the broad spectrum anti-epileptic. Clonazepam, clobazam, both are benzodiazepines, and acetazolamide, a carbonic anhydrase enzyme inhibitor. All are drugs useful for treatment of absence seizure. Whereas the right answer for your first question, carbamazepine. Carbamazepine, sodium blocker, that is wonderful drug for treatment of partial seizure. Carbamazepine, drug of choice for partial seizure. and it's also wonderful drug for temporal lobe seizure. So carbamazepine as an anti-epileptic, it's a sodium channel blocker useful for treatment of partial seizure and temporal lobe seizure. But you should know carbamazepine having some non-epileptic use also. Anybody want to answer? Anybody? What is the most important indication of carbamazepine as a non-epileptic use? It's a drug of choice for trigeminal neuralgia. Very important, very important. Also useful for glossopharyngeal neuralgia. So useful for treatment of neuralgia pain. That's especially for trigeminal. And it is also having mood stabilizing property useful for bipolar disorder. You should know, doctor, anti-epileptic having mood stabilizing property. We have topiramate, valproate, valproate, carbamazepine, lamotrigine. The mood stabilizers are valproate, carbamazepine, lamotrigine. So carbamazepine mood stabilizing property useful for bipolar. And one more point, doctor, carbamazepine having SI-ADH property, thereby having water retention. This property useful for treatment of diabetes insipidus. Yes, SIADH action. This important. I think old question. Which is the anti-epileptic having high risk of SIADH? Carbamazepine and carbamazepine derivative. We have what they call oxcarbazepine. Oxcarbazepine. This also having very high risk of causing SIADH. That's about question number one, doctor. So far, we done anti-epileptic chapter. Very important. My prediction, if is right, definitely one question. Either regarding mechanism action or use or adverse effect of anti-epileptic drugs are very, very important. Just revise. Okay. Now, second question. Ready? Which of following statement is false regarding treatment for hypertension? Come on, start working. Which of the following is false regarding treatment for hypertension? Unilateral contraindicated in bilateral rheumatolosis. Yes, it's a true statement. Losartan is not preferred for treatment of hypertension in gout patient. False statement. We'll explain. Diuretic not preferred for treating hypertension with dyslipidemia is true statement. Nifedipine is not preferred for treatment of hypertension in heart failure. True statement. We will explain everything. The right answer for the question, option number B. Those who voted option B, very important, is good. Good. Look here. Losartan, a angiotensin receptor blocker, ARB, having uric property. Uric property. That means it's preferred for treatment of hypertension in gout patient. Okay. Yes, good. Now we know we go for discussion. Why answer B? Why not other? That's what you need. For the question number 2, look at the first option. Unilateral contraindicated in bilateral. Yes, true statement because unilateral, one of the ACE inhibitor. You should know angiotensin converting enzyme inhibitors are contraindicated in bilateral renal artery stenosis. Why? Why? For example, look here. In case of bilateral renal stenosis, if there is stenosis bilaterally, in this case, the GFR totally depend upon efferent arteriolar pressure. Remember, in case of bilateral renal stenosis, the GFR depends upon efferent arteriolar pressure. When you give ACE inhibitor in this case, they are vasodilator. They dilate the efferent arteriole. When efferent arteriole dilated, there's a fall in glomerular filtration pressure. This will cause reduction of GFR, thereby causing acutely kidney failure. So in this patient, ACE will cause acute renal failure. That's why ACE inhibitors are contraindicated in bilateral relationship. One more point, they also contraindicated in pregnancy because their teratogen, they causes fetal renal and pulmonary agenesis. Agenesis. So the absolutely contraindicated for treatment of hypertension in pregnancy. Of course, all the ROS pathway blocker. When it's a ROS pathway blocker, like beta blocker, SCVT or ARB, even all those tune antagonist, spironolactone, all will cause adverse effect of hyperkalemia. So SVT are contraindicated in hyperkalemia also. So remember, for the first statement, ACE inhibitors are contraindicated in bilateral rhinosis in pregnancy and hyperkalemia. Look at the option B. That is hypertension with gouts. Whenever you want to treat a hypertension in gout patient, here the preferred choice can be either go for amlodipine or go for losartan, because among the CCB, amlodipine having uricose uric property. Among the ARB, losartan having uricose uric. So the best antihypertensive for treatment of hypertension with the hyperuricemia go for either amlodipine or losartan. Whereas in this case, better avoid what? Avoid thiazide and loop diuretic. The thiazide diuretic, loop diuretic causing adverse effect of hyperuricemia. So they're not good for treatment of hypertension in this patient. Okay. And look at the option number C. That's hypertension with the hyperlipidemia. In this case, the preferred antihypertensive can be either go for SVTOR or ARB or alpha 1 blocker like prazosin. Prazosin having favorable effect on lipid profile, or we can try CCB, but better avoid thiazide diuretic and beta blocker because they causes hyperlipidemia. That is option C. Coming to option D, super important question. Option D, hypertension with the heart failure. In this case, to control hypertension, better go for acimidor or go for ARB or go for diuretic, or in severe hypertension with heart failure, we can also go for sodium nitroprusside. Whereas super point, hypertension with heart failure. In this case, for treating hypertension, don't use CCB. So what Goodman Gilman says, CCBs are not suitable for treatment of hypertension in CCF. Better go for only some exception. Usually CCBs are not preferred in the presence of heart failure. Exception, amlodipine and felodipine. It is important point actually. Usually CCBs are contraindicated in heart failure. Exception, either amlodipine or felodipine. So these are only two CCB can be preferred for treatment of hypertension in heart failure. Remaining CCB are not preferred in heart failure. Okay. And then beta blocker. Beta blocker having negative inotropic effect, they may further decrease in cardiac output. Be careful. Be careful. But one question to all people, can you please answer in the chat box? I'm telling, be careful about using beta blocker in heart failure. But you should tell anybody, name some beta blocker approved for treatment of heart failure. In chronic heart failure, to prevent remodeling, to prevent mortality, we can use some beta blocker. Anybody? Name some beta blocker got approval for treatment of chronic failure. Yes, most importantly, carvedilol. Other drugs are metoprolol succinate, then bisoprolol, one more drug, nebivolol. Okay. The most important, carvedilol. Very good, very good. Very important, carvedilol. Other drugs are metoprolol succinate, bisoprolol, and nebivolol. Okay, that finishes the second question. Now, coming to question number 3. Ready? A 29-year-old software engineer presenting to the neurological clinic with a history of recurrent headache for the past 8 months. The headache described as unilateral, thrombin in nature with photophobia, phonophobia, occasionally vomiting. They occur around 6 to 8 times per month, triggered by sleep deprivation and stress. A self-medication, the over-the-counter painkiller, having partial relief. The neurology examination and MRI was normal. What is the most appropriate next step to prevent further episodes of headache in this patient? Answer? Anybody want to answer? Actually, this case of migraine is headache, typically describing good migraine, and in this they want to prevent further headache. That means they want prophylactic therapy for this patient. Anybody want to answer? What the best answer for this question? Option A, smart triptan. Option B, ubrogepant. Option C, lasmediton. Option D, flunarizine. What answer? The right answer for question, go for option D, flunarizine. Remember, flunarizine, one of the key type of calcium channel blocker approved for prophylaxis of migraine. Okay. So here, so point one, fluorescent. And you should know which are the other CCB having role in prophylaxis. We also go for verapamil. Remember, verapamil and flunarizine are the CCB got approval for prophylaxis. But look at the other options: sumatriptan, ubrogepant, lasmiditan. Triptans are 5-HT 1BD agonist, the vasoconstrictor. So triptans are the drug of choice for acute attack of migraine. For acute attack, triptans are choice. Ubrogepant, it is Giban. Giban means calcitonin gene related peptide antagonist. It is also useful for acute migraine only, not for prophylaxis. Then lasmediton, so latest drug, it's a 5-HT 1F agonist. It is a vasoconstrictor useful for acute attack of migraine. So all the option A, B, C are useful only for acute. So in this question, I want to prevent further episodes. So I want to go for prophylactic. In this, I just want to tell some new point, doctor. When I say new point, the new points are CGRP antagonist and 5ST 1F agonist. Please concentrate. See, there's something called calcitonin gene related peptide. This peptide is having vasodilatory property. So to control the migraine, today we have something called CGRP antagonists. Who are they? Please watch. We have something called ubrogepant, CBGepant, rimigepan, and etogepan. All the drug name ending with something called Giban. Giban. Ubrogepant, CBGepant, rimigepan, and etogepan. In this, most of the drugs are useful for acute attack of migraine orally. But one important, ubrogepant, a oral drug useful for acute. Civigepan, only nasal spray form useful for acute migraine only. Rimigepan, oral drug useful for both acute and prevention. Etogepan, only for prevention. So this and this are only for acute. And then look at the other. We have something called monoclonal antibody targeting against CGRP, drug name erinumab, fremanezumab, galcanezumab, and eftinezumab. In this, the first three drugs are given injections subcutaneously once in a month for prevention, prophylactic. Eftinezumab given intravenous infusion once in 3 months for prevention. So all these MEB are useful only for prophylaxis. And finally, one latest point. For treatment of migraine, we have one more drug called 5ST1F agonist called lasmediton. The latest, it's a vasoconstrictor approved for treatment of acute migraine. For useful for acute migraine. That finishes some latest point. But you should tell anybody what is the most commonest drug useful for prophylaxis of migraine? Come on, doctor. Name the most common drug. It is beta blocker like propranolol. That's the most common drug. Or else we can go for CCB like flunarizine. Or else we can go for anti-epileptic. There are some anti-epileptic like topiramate, or valproate. Okay, topiramate, valproate can be useful. Okay, good. So you should know the latest drug is lasmiditan. So migraine chapter very important. Please go through that. Okay. Now we move to next question. Ready? Very interesting question. Which one of following drug? Which of following drug antidote bears incorrect match? Can you please answer? Which is incorrect match? Option A, methadone. Again, drug name, doctor, drug name, and the antidote. Which is incorrect? I'm waiting. Can you please answer? Yes, good. Answer B. Very good. Come on. Methadone opioid. For opioid antidote naloxone. Methyl alcohol. For this antidote, fomepizole. Fomepizole. Whereas flumazenil antidote for benzodiazepine. Okay. For atropine, fistigmin. For amitriptyline, answer sodium bicarbonate. So rapid fire round. I'm going to show some important drug. You should tell the antidote. Come on, ready? Start firing. Point one. Antidote based questions are frequently coming after. So my first point. Ready? I given drug poisoning. You should mark the answer. Ready? Start. For benzodiazepine poisoning, the antidote is flumazenil. It's a competitive antagonist of benzodiazepine. Okay. Lasmiditan is a vasoconstrictor useful for acute. Come on. Adria. Angelio. Plasmidon 5:1 F agonist causing vasoconstriction useful for acute attack migraine. Okay. Now, for morphine poisoning, the choice will be IV, intravenous naloxone. Remember, IV naloxone, a short-acting drug. So when you give naloxone, patient become conscious. But because of short acting, we don't totally depend upon this. Following conscious, we put them on oral naltrexone. Oral naltrexone as a maintenance. Okay. And then tricyclic antidepressant. For them, the first line antidote go for bicarb. Here, the presentation will be metabolic acidosis. So, the first line treatment should be correction of acidosis by injecting bicarbonate. Of course, you should study about TCA poisoning. They may cause cardiotoxicity and also convulsion. So you should study how to treat cardiotoxicity, how to treat convulsion, all these things. But in general, antidote for TC poisoning, go for sodium bicarbonate. Okay. Methadone, Arjun Reddy, methadone, so opioid. For opioid, methadone, morphine, all are opiates. For all opioid poisoning, antidote, go for naloxone. Okay. And then for methanol poisoning, even for ethylene glycol poisoning, we go for fluibuzole. Fluibuzole is a alcohol dehydrogenase enzyme inhibitor. That's a specific antidote for methanol poisoning as well as for ethylene glycol poisoning. Of course, atropine, atropabelladonna, or datura poisoning. Very important. For this poisoning, the specific antidote go for physostigmine. See, physostigmine, a choline esterase enzyme. Choline esterase inhibitor. It's going to crosses the blood-brain barrier, so lipid soluble, able to control both CNS and peripheral symptoms of atropine. So the best drug of choice for treatment of eight poisoning, go for physostigmine. Okay, and for digoxin poisoning, digibine. Of course, very simple but important. For parastamol poisoning, the antidote go for N-acetylcysteine. The cysteine going to increases synthesis of glutathione, thereby overcoming the problem. Okay, so the antidote for paracetamol go for N-acetylcysteine. Of course, you should know it is also a mucolytic. It's also a mucolytic agent. Okay, right. So we done some important poisoning and the specific antidote. Now, next question. Ready? A 60-year-old woman with hypertension and recurrent kidney stones started on diuretic. Which of following diuretic most likely to be to help in reducing calcium loss in the urine and prevent kidney stones? Very interesting question. Come on, name the diuretic going to inhibit calcium excretion, thereby useful for treatment of calcium stones. Answer? Yes, good, ma, good. Anshita Jain. Answer B, fantastic. Thiazide going to cause calcium reabsorption, thereby preventing calcium excretion, preventing stone formation. Good, good. Whereas loop diuretic loses calcium in urine, causing calciuria, thereby causing stone formation. Okay. Now, answer is option B. Related to this question, please revise some point. Look here. Calcium stones and diuretic. What? The diuretic causing calcium stone mean think of loop. Loop diuretic causing calciuria. The calciuria going to form stone formation. Whereas diuretic useful for treating stone mean thiazide. Thiazide causing calcium reabsorption by preventing stone formation. In this junction, you should also note, look here. Can you please make a rapid fire answer? Come on, doctor. Related to this question, extra one. Imagine there's a case of liver cirrhosis having ascites. For treating the ascitic edema, I want diuretic. Name the best diuretic for treatment of liver cirrhosis with ascites. Best is go for spironolactone. See, in cirrhosis liver, there's a hyperaldosteronism. So for treat this case, I need aldosterone antagonist, so-called spironolactone. Whereas name the diuretic contraindicated in liver failure, it is astazolamide. Astazolamide in liver failure cases going to cause accumulation of ammonia, thereby may cause hepatic encephalopathy. So, carbonic anhydrase enzyme inhibitors are contraindicated in liver failure patient. Okay. Related to this, one more super interesting question. Can you please answer? One, heart failure and pulmonary. In this case, I want 3 points. Anybody? Name the diuretic useful for rapid relief of symptom in acute LVF. I want rapid relief of symptom of breathlessness. Answer: it is loop diuretic like furosemide. Furosemide has vasodilatory property plus diuretic property, and it is the first diuretic of choice for managing breathlessness in acute heart failure. Whereas remember, furosemide useful only for symptom relief. It's not going to modify heart diastole. So, question: name the diuretic useful as a disease modifying drug in heart failure. That is aldosterone antagonist like spironolactone, because you know ROS pathway going to cause ventricular remodeling. So when it's a ROS blocker, in this aldosterone blocker comes, so spironolactone. Whereas anybody want to answer? Name the diuretic contraindicated in the treatment of pulmonary. It is mannitol. Mannitol, a osmotic diuretic, it's going to cause water retention from and going to expand the extracellular fluid volume, so unsafe in heart failure. That finishes some interesting portion, doctor. Now, question number 6. Ready? A 28-year-old athlete diagnosed with hypertrophic obstructive cardiomyopathy (HOCM) after presenting with he HOCM present with exertional syncope. Echo shows asymmetric septal hypertrophy with a dynamic LV outflow obstruction, which are for drug contraindicated in this patient. Answer? Yes, fantastic, fantastic, good. Answer C. Digoxin, a inotropic drug, contraindicated in the case of HOCM. Why? I will explain. For this question, I just take 1 second. Very important, very important. Listen. Look here. When you say hypertrophy, obstructive myopathy, look here. Septum become hypertrophic, left ventricle wall become hypertrophic. Thereby, what is the problem? The left ventricular chamber size become very, very less. When the chamber size less mean filling become very, very less. When filling less mean poor cardiac outputs, thereby present is syncopal. So for treating this case, what I should do? One option surgically we can do something. Medically mean the best option. What? Here, I want to give adequate amount of cardiac output. So the concept is give time for the ventricle to fill adequately. For that, you should do one thing. Reduce the heart rate. First point. Reduce heart rate. When you reduce the heart rate, the time for ventricle to fill adequately. And then second concept, avoid inotropic. Avoid inotropics because Harrison book says when you use inotropic agent, they're going to cause more and more aortic obstruction. Already hypertrophic obstructive myopathy. When you use inotrope, they're going to further worsening outflow obstruction. So it's a concept that means I want to reduce the heart rate. I don't want to have force of contraction. That means I should give a drug decreasing heart rate, a drug decreasing force of contraction. It is what I am going to use. Here the best option go for beta blocker like propranolol. So the fantastic drug for treating HOCM go for propranolol. If not, suppose patient asthmatic, I can't use propranolol. In this case, alternative go for verapamil. Both are reducing force contraction, reducing heart rate. But one question to all people: if you tell this answer, NEET PG waiting for you only. Anybody want answer? Name one direct myosin inhibitor going to inhibit myosin activity, thereby reducing force contraction approved for treatment of HOCM. Anybody? Name the direct myosin blocker. Answer Mavacamten. Expect the question. Mavacamten, a direct myosin blocker. Mavacamten. Okay. And one more doctor. One more thing. What are the drugs to be avoided? Avoid using inotropes. Somebody asking, propranolol will cause reflex tachycardia. Hey, Anshuda Jain, how can a propranolol cause reflex tachycardia? Propranolol a beta blocker. They're going to block the beta in the heart, causing only bradycardia. They never cause tachycardia. Propranolol will never cause tachycardia. Okay, so remember. So question: avoid using inotropic agent. Avoid using vasodilator and diuretic because they're going to reduce the filling of ventricle. That's why my question answer digoxin. Digoxin, yeah, inotropic agent is going to be contraindicated in HOCM. Okay, very fantastic. Those who answer very good, very good. Okay, now a 68-year-old man with non-valvular atrial fibrillation being cancelled for stroke prophylaxis. Here, stage 3 CKD, GFR 45 ml. Okay. Which of following anticoagulant most appropriate in this patient? Little bit tough question. Patient needs prophylaxis for preventing thromboembolism, but patient having CKD. So, question in CKD patient, which is the most preferable anticoagulant among this option? Ready? Go one by one. Dabigatran undergo renal route of excretion, so it is not good for this case. And you should know dabigatran is oral direct 2A inhibitor. That's not good. Rivaroxaban. Pick 7. Those drugs name ending with X7. These two are orally given, direct, 10A blocker. In this, the Pixaben may be preferred in CKD. So answer for question option C. Whereas Rivaroxaban undergo maximally through kidney. Maximally through kidney. So answer Enoxaparin. It is one of the LMWH. They undergo renal route of excretion. So unsafe in kidney failure. So what do you do? I just give a list. Which are the anticoagulant or unsafe in kidney disease? So for the question number 7, please go through. That is anticoagulant and the major route of excretion. Okay. Warfarin undergo mainly metabolism in the liver. So safe in kidney failure. Dabigatran, a oral 2A blocker, it is undergoing renal. So dabigatran contraindicated in kidney failure. Rivaroxaban, Pixaben, both are oral 10A blocker. In this, Pixaben safe in kidney disease because it maximally goes through liver, but it goes through liver as well as kidney. So among the oral 10A blocker, Pixaben suitable in CKD patient. And then LMWH undergo renal. Heparin. Anybody want to answer? Heparin undergo metabolism or inactivation mainly by reticuloendothelial system. So heparin safe in kidney failure. And then fondaparinus totally goes through kidney, unsafe in kidney failure. Argatroban, that is injectable direct 2A blocker. Remember, among the injectable 2A blocker, Argatroban goes through bile, so safe in kidney failure. Whereas all other injectable direct 2A blocker like leprodane, hirudane, bivalrodane, all are goes through kidney. So among the injectable direct 2A blocker, safe is Argatroban in kidney failure. This is dry area but important. Please go through this. Next question, come on. I need your participation. Please answer. A 48-year-old patient with heterozygous familial hypercholesterolemia already on maximum dose of atorvastatin and estimate, but even then LDL cholesterol remain high. His the physician adding one drug called alirocumab. Which of following is the correct statement about alirocumab mechanism action? Can you please answer? Patient was already on adequate dose of maximum dose of atorvastatin and estimate, but still patient LDL not controlled, so they want to add alirocumab. Anybody? What answer? Yes, good. Answer. The alirocumab, a monoclonal antibody targeting against PCSK9. They're going to prevent the degradation of LDL receptor. So, answer is option number D. It enhances LDL receptor recycling. Remember, answer for question option number D. I'll explain. 1, 2, 3. Everything I'm going to discuss is a very important topic. Listen carefully. First point, look here. You know, liver is the one factory where cholesterol synthesis is going to happen. Please watch. In the liver, we have HMG-CoA actase. It is the rate limiting enzyme in the synthesis of cholesterol. We use statin. Statin acting by inhibiting HMG-CoA actase. So, one. The first point, the mechanism section, statin acting by inhibiting HMG-CoA reductase, thereby inhibit cholesterol synthesis. Point 1. Point number 2. When you inhibit cholesterol synthesis by statin, they cause upregulation of LDL receptor in liver cells. This in turn going to cause engulfing. They're going to taking LDL from the periphery, thereby statin decreases LDL also. So remember, statin decreases total cholesterol and LDL. Total cholesterol reduced because the inhibiting synthesis. LDL decrease because they cause upregulation of LDL receptor. Now question starts. The LDL receptor undergo degradation by something called PCSK. PCSK means pro-protein convertase subclinic 9. No question. The LDL receptor undergo degradation. No. So to prevent the degradation of LDL receptor, I am going to inhibit the PCSK. That is called our MC question. Alirocumab and evolocumab. Remember, alirocumab, evolocumab are PCSK9 blocker. They are going to increases LDL receptor in the liver cells, thereby decreases LDL cholesterol, and they're given injection subcutaneously. Remember, alirocumab, evolocumab are monoclonal antibody targeting against PCSK, useful for lowering LDL cholesterol and given injection subcutaneously. Okay. In this junction today, you should know one more point. Look here. Alirocumab, evolocumab are PCSK9 blocker. But today we have one thing called inclisiran. What is the inclisiran? Nothing but it's a drug going to inhibit synthesis of PCSK. It is going to inhibit synthesis of PCSK9. So inclisiran. Okay. And finally, what are the other options? Look here. Imagine the intestine. A patient taking cholesterol diet. The dietary cholesterol goes inside the intestine. You want to see? Come on. I'm opening the intestine. Now, see, the cholesterol goes inside intestine. From the intestine, the cholesterol undergo absorption. The absorption done by one transporter called NEETPG, NPC1L1. Now, all must answer. Anybody? Name the drug blocking NEETPG C1L1 transporter, thereby inhibiting absorption of dietary cholesterol. That is acetamib. So question, acetamib, a drug inhibiting Niemann-Pick C1L1 transporter, thereby inhibiting absorption of dietary cholesterol. Okay. And finally, one question, what is pembidic acid? Pembidic acid is the ATP citrate lyase inhibitor. This enzyme involved in synthesis of cholesterol, thereby reducing LDL. So, pembidic acid is a ATP citrate lyase enzyme inhibitor useful for decreasing LDL cholesterol. Finishes cholesterol lowering agent based MCQ. Next, we're going to ready? A 58-year-old obese patient with the type 2 diabetes started on medication that activating AMPK protein kinase and reduces hepatic gluconeogenesis. Which of following adverse effects should be the physician should monitor closely? Yes, answer. Yes, good, good, good. Here we are talking about metformin. Metformin, one of the AMPK activator, a oral anti-diabetic, a very good drug for type 2 diabetes. It may cause seriously adverse effect of lactic acidosis. Okay. Anyway, just 2 minutes, two important points. When you say metformin, remember metformin, a AMPK activator, thereby reduces glucose output from the liver. So the main mechanism action, metformin reduces glucose output from the liver. Point number 2, very interesting question. Metformin also causes insulin sensitization in the periphery, adipose tissue, muscle tissue. My metformin causes insulin sensitization. That means overcoming insulin resistance, and thereby insulin start functioning. Thereby insulin pushing the glucose into tissue. Now question goes to all people. Anybody? Insulin pushes plasma glucose into tissue by activating dash glut. Answer please. Insulin going to stimulate dash glut, thereby plasma glucose are transported into tissue. Glut 4. So my metformin activating insulin, thereby insulin stimulate glut 4. Okay. Glut 4. Come on. Dushmesh, but GLUT2 is carrying glucose to pancreatic beta cell, thereby promoting insulin release. For insulin release, we need GLUT2, whereas insulin activating GLUT4. Okay. And finally, metformin minimally acting on intestine, where they decreases absorption of dietary glucose. It's a minor mechanism. Okay. And finally, what are the adverse effect? My question dealing with the ADR. When I say metformin, the most common ADR GI toxicity like nausea, indigestion, diarrhea. But they also causes B12 deficiency, megaloblastic anemia. But you should know metformin rarely causing lactic acidosis. Anybody want to answer? Metformin causing lactic acidosis, this problem will be seen in some risk factor. Name some risk factor that are going to precipitate lactic acidosis metformin. That's your negative metformin in the presence of kidney failure, or in the presence of liver failure, or in the presence of cardiorespiratory insufficiency, or in chronic alcoholism. In this patient, when they give metformin, there is a risk of lactic acidosis. Very important, very important. What are the risk factors that going to cause lactic acidosis of metformin? Very important. Okay, with this, we move on to next question. Question number 10. Ready? Interesting question, easy question. A 30-year-old woman with a newly diagnosed grave disease started on methimazole. Which of following side effect potentially life-threatening adverse reaction in this patient? Come on, patient is on methimazole. In this patient, what is the dangerous adverse effect? Anybody? Answer is option number. Yes, yes, yes. Fantastic. Option C. Very good, very good. Just give 1 second time, doctor. Just 1 second time. Yes, beautiful. Answer C. Now look here. Methimazole, one of the thioamide. When I say thioamide, you should know what are the important adverse effects. The thioamide mean we have methimazole, also we have propyl thiouracil. What are the idea? They cause one thing, skin rashes, maculopapular skin rash. Other point, they cause agranulocytosis, especially methimazole causing maximum risk of agranulocytosis. And one more point, they also causing hepatotoxicity, especially propyl thiazide causes maximum risk of liver damage. All these are adverse effect of thiamide. Of course, one important question, when you talk about methimazole PTU, you should know what is the problem when using this in pregnancy. Very important, very important. When you give thioamides like methimazole or PTU for treatment of hyperthyroidism in pregnancy, they are teratogen, causing what? Aplastic cutis, that is absence of skin, and coronal atresia, nasopharynx atresia. So the teratogen. That's why all must answer. Anybody? Which is the relatively safe drug in pregnancy? Go for PTU. It is relatively safe. Why safe? It is strongly binding with the plasma protein. Very strong plasma protein binding. So less chance of crossing placenta, less adverse effect. But the problem is it should be given only for 3 months, not more than 3 months. When you give more than 3 months, it may cause adverse effect of severe liver damage for the mother. For the mother. So it is given only for first trimester. So from second trimester, we go for methimazole. This topic very very important. It's very important for pharmacology, even for OG, very important. Okay. Next question. Ready? A 28-year-old female with irritable bowel syndrome presenting with diarrheal dominant IBS. She has no signs of infection or inflammation. Which of following is an appropriate pharmacology treatment for this case. Anybody? Patient having diarrheal dominant irritable bowel syndrome. For this case, among the four options, what the best? Best is go for? Yes, good, good. Option number B, loperamide. Fantastic, fantastic. Loperamide, a opioid having anti-motility action useful for treatment of diarrhea. Okay, okay. Now you should know what is linaclotide, what is lubiprostone, and what is polyethylene glycol. All the other drugs are useful for treatment of constipation. Here, polyethylene glycol is one of the laxative useful for treatment of constipation. Remaining, I just explained. What is linaclotide? Remember, linaclotide and pliconatides are a CFTR. Come on, CFTR activator. By activating CFTR, they're going to stimulate the guanyl cyclase enzyme, thereby increases chloride rich secretion, thereby promoting intestinal motility. Remember, linaclotide and pliconatides are guanyl cyclase activator. That's one point. Next option, I want to think of lubiprostone. What is lubiprostone? Prostone. It's going to bind with the prostaglandin E2 receptor in the intestine, and it's a direct chloride channel activator. Very important, very important. It's a direct chloride activator useful for treatment of constipation. And now one super interesting question. Anybody? I have one drug called Tina. Please watch the diagram and tell me what is the mechanism action of Tina. Please watch and tell me. Imagine it is the lumen of the intestine. It is intestinal cells. Now tell me, anybody want to answer? What is the mechanism action of Tina? It's a drug called sodium hydrogen exchange. Sodium hydrogen exchange inhibitor. Sodium hydrogen exchange inhibitor, thereby inhibiting sodium absorption. They're going to accumulate sodium and chloride in the lumen of intestine, promoting motility, useful for treatment of constipation. So remember, Tina is a sodium calcium exchange inhibitor. Okay. Next question. A 66-year-old man with atrial fibrillation. Okay, okay. Tulasi Yadav. Okay, okay. I stick on to nearby mic. Okay, ma. Okay, ma. Okay. Next, the age evaluation brought to emergency department after a fall with the signs of intracranial hemorrhage. He was recently started on dabigatran for stroke. Which of following agent most appropriate antidote? Anybody? What is the antidote for dabigatran? Answer? Yes, good. Answer: idarucizumab. A monoclonal antibody. It's a drug useful for treatment of bleeding due to dabigatran. I just explained. Protamine antidote for heparin. Vitamin K antidote for warfarin. Anti-sulfur is an antidote for oral 10A blocker. Now, just to watch my diagram, look here. This is a very interesting slide. Can you please answer? Thrombolytic drugs like streptokinase, alteplase. For treatment of thrombolytic drug induced bleeding, what is the antidote? Anybody want to answer? What is the antidote for thrombolytic drugs? The best antidote go for epsilon aminocapric acid, ESCA, or we can try tranexamic acid or aprotinin. But the most specific antidote go for epsilon aminocapric acid. Okay, and then dabigatran. It's oral direct to a blocker. For this case, antidote idarucizumab. This is what our question. And then oral 10A like Epic 7, Edox 7. For this case, antidote anti Z alpha. Okay. And finally, one question. For It for dabigatran and for oral tiny blocker for both we have one common antidote that is called siraparentak. Remember, siraparentak is a common antidote for both direct 2A and tiny blocker. Drug name siraparentak. This is very important, very important. Okay. Next question. Ready. Which of following antidepressant is the norepinephrine dopamine reuptake blocker? Norepinephrine dopamine reuptake inhibitor associated with weight neutrality and smoking cessation. A drug useful to control smoking habits, also weight neutral, neither causing weight gain or weight loss. Best name the antidepressant. Answer yes, good. Answer B period. It's a NDRI. It's a NDRI, a antidepressant useful for treating depression as well as useful for treatment of control of smoking habit. Sometimes useful for treatment of obesity. Also useful in ADHD to promote attention span. But the only problem, it may cause anxiety, adverse effect. It may cause anxiety problem, sometimes causing seizure problem. That's what B problem. Coming into option A, sertraline. Sertraline, one of the SSRI. Duloxetine, SNRI, very important, SNRI. This SNRI, wonderful drug for treating depression as well as useful for fibromyalgia, body pain, are also useful for controlling stress incontinence of urine. That is to control urination while coughing or while sneezing because they're going to improve erythral tone. Mirtazapine, it's a alpha 2 blocker with 5-HT2 blocking property, a wonderful antidepressant having additionally antihistamine property also, thereby useful for treatment of depression with insomnia because of antihistaminic causing sedation, useful for treatment of depression with insomnia. Okay. Now one doubt I have. When you talk about smoking, a antidepressant useful to control smoking, bupropion. Just watch. The best antidepressant for treating smoking is go for bupropion. It's NDRI. This is what I discussed. But hereafter, within a second, you should answer all my questions. Ready? Name the anti-smoking drug called most effective drug. Name the most effective drug to control smoking. It is vernicillin. What is vernicillin? Vernicillin is a alpha 4 beta 2 partial nicotinic. It's a alpha 4 beta 2 partial nicotinic agonist, most effective drug, but may cause adverse effect of suicide. It may cause suicidal tendency. Very important. And one more point after, it is also got approval for treatment of dry eye disease, useful for treatment dry eye disease. Okay. And finally, name the anti-smoking drug available as a patch. That is called nicotine. Nicotine available as a patch form, inhaler, lozenge, and chewing gum. It's available as a patch, inhaler, lozenge, and chewing gum. But no tablets. No tablets. Okay. Next. Name the anti-epileptic useful to control smoking. That is topiramate. Remember, topiramate, a anti-epileptic useful for migraine prophylaxis, control of smoking habit, some control of alcoholic habit also, and very important, it causes adverse effect of weight loss and kidney stones. Very important. Nephrolithiasis. It causes weight loss and kidney stones. Okay. And then 14th question. Ready? A 60-year-old woman presenting with the complaints of urinary urgency, increased frequency, and urge incontinence. After excluding other causes, she diagnosed with overactive bladder. Which of following drug is most appropriate for this patient? Answer please. For treatment of OAB, what the best answers? Go for option B. Very good. Oxybutynin. It's a anti-muscarinic. Anti-muscarinic agent. It's anticholinergic. Going to relaxes detrusor muscle, causing urine retention. Useful for treatment of overactive bladder. Whereas look at the other option, bethanacol. It's an M3 agonist. It's going to promote prokinetic activity. It is useful for treatment of post-operative urinary retention. Useful for treatment of retention. And then tamsulosin, alpha 1A blocker, useful for relieving symptoms of benign prostatic hypertrophy. Of course, phenostate, it's a 5 alpha. 5 alpha reductase inhibitor, useful for benign prostatic hypertrophy to control size of prostate. Phenostate inhibiting conversion of androgen into dihydrotestosterone. But one point, can you please answer? Phenostate in elderly male useful for this case. Anybody? What is the use of this drug in young male? In young male, what use of phenostate? In youngsters, useful for treatment of male male pattern of baldness, useful for treatment of alopecia, for treatment of male pattern of baldness. Okay. Now, question to all people, can you please answer my question? Read. Sometimes they may ask image based question. Please answer. That is, look here. I'm putting bladder picture. Drugs acting on bladder. M3 agonist mean think of bethanacol. Bethanacol, cholinergic drug. It's M3 agonist, useful for treatment of urinary retention. Next, one super interesting question. Anybody? Name any beta 3 agonist acting on the blood active. Name any beta 3 agonist. Mirabegaron. Mirabegaron. One more drug called V. Begaron. Both are going to cause detrusor relaxation, that be useful for treatment of overactive bladder, useful for OAB. And then SNRI, Duloxetine, one of the SNRI, useful for treatment of stress incontinence, controlling urination while coughing. Last one, alpha 1 blocker, just now told. Tamsulosin, useful for treatment of symptoms of benign prostatic hypertrophy. So, drugs acting on bladder also very, very, very important. Okay, almost we are finishing. Now, just one more question I'm going to discuss. That's the last question. Ready? My part is only ANS, CVS, CNS, and Endo GAT. Remaining part will be taken by other faculty, so don't react. In my area, I predicted the most important areas. Now, last question. A 58-year-old man with the primary open angle glaucoma given nitarsudil. Which of the following best describe its mechanism and adverse effects? So I want to know what is the mechanism action of nitarsudil and what is the adverse effect. Ready? The right answer, nitarsudil, it's a Rho. So Rho kinase enzyme blocker. That means the right answer will be option number C. Very good. Option C. It's the Rho kinase enzyme blocker, going to enhances they're going to increases aqueous outflow through trabecular route and may cause adverse effect of conjunctival hyperemia. For the question 15, I just take another 1 minute time. Very, very, very important. Anti-glaucoma drugs mechanism action and the adverse effect. Very important. Expect a question. Please watch. Look here. When you talk about drug therapy for glaucoma, there are two type of drugs. Some drugs are decreasing aqueous production. Some drugs are promoting drainage. See, in the silly body, in the silly body is the source of aqueous. So, some drug acting on silly body decreases aqueous production. What are the drug acting on silly body decreasing aqueous secretion? Mnemonic A, B, C. A for alpha agonist like apraclidine, brimodine. B for beta blocker like timolol. C for carbonic anhydrase enzyme blocker like dorzolamide, brinzolamide. So These are acting on city body, decreases aqueous production. Whereas some drug going to promote drainage. What, for example, I have one thing called M3 agonist called pilocarpine, a cholinergic drug going to cause meiosis. By causing meiosis, they're going to widen the angle of antechamber, thereby promoting drainage across via calcium. So, pilocarpine promoting drainage across via calcium. That's one point. And other drug promoting drainage job, look here, we have something called prostaglandin, PGF2 alpha, like latanoprost, bimatopras, travoprost, and sometimes adrenaline, buprenorphine. Buprenorphine, a pro-drug of adrenaline. They may promote drainage via EVO scale notes. Okay, and finally, our question. There are some drug called nitazoxanide and repasturil. They are called rho kinase enzyme blocker. They promoting drainage across via tobacco routes like pilocarpine, your nitazoxanide repasturil also going to promote drainage through tobacco. And finally, going to adverse effect. Come on. Adverse effect also very much important. Can you please make a rapid answer? Name the drug useful in glaucoma causing adverse effect of lead lag. That is your apraclonidine alpha to agonist. Name the drug causing anti-uveitis brimodine. So remember, apraclonidine, brimodine both are alpha to agonist. Okay. And very important question. A patient taken some eye drop developing difficulty in breathing. What could be the drug? Answer, beta blocker like timolol. Timolol, a non-selective beta blocker going to cause bronchospasm. And then name the group of drug useful for glaucoma may cause nasolacrimal duct obstruction. Again, beta blocker, rarely causing nasolacrimal duct obstruction. And another very, very important question. Name the group of drug useful for glaucoma causing adverse effect of iris pigmentation called heterochromia iridis, sometimes causing hypertrichous eyelash overgrowth, and cystoid macroedema. Answer, all these are adverse effect of what? Prostaglandin, PGF2 alpha agonist. And one more thing also, name the drug causing cataract. Name the drug useful for glaucoma causing cataract mean think of ecothypin. Ecothypin, one of the organophosphorus compound, irreversible choline esterase enzyme blocker, but we don't use it anyway, just keep in mind. And these are adverse effect of prostaglandin, PGF2 alpha, like latanoprost, bimatopros. And finally, important, when I discussing the 15 question, I just tried everything from all the system. So most of the question will be repeated. So my kind advice, please go through our DVT notes, Damsonian. Please go. Non-Damsonian, please borrow from somebody and go through DVT notes. And time permits, go through our PYQs. Okay. And also Predictor series and LRR, live repetition. This is more than sufficient, doctor. Okay. So with this, I'm finishing all my 15 questions. If we have any doubts, it's time for doubt solving. I'm waiting for next one or 2 minutes. Can you please ask any doubts? Oh, mini 12 out of 15. Okay, very good. Great revision. Yeah, very good. Thank you for good feedback. And anybody got 15 out of 15, doctor? Anybody? Anybody in the crowd got 15 out of 15? More than 12 is a great rank, man. Definitely going to get a very good seat. Okay. So anyway, may God bless you. All the very best, doctor. Definitely God will be with your side. So don't worry. Be cool, compose, enjoy studying, and definitely you're going to see success. So my best wishes for all people. Thank you very much. Thank you very much for the great opportunity. Thank you all.